So before we begin to talk about the drugs used in Parkinson's disease and a subtopic of psychosis, we first need to understand the basic anatomy as to what are the organs or what is the area in the brain that is going to be affected in the disease of Parkinson's. So to understand that, let us first take a look about the anatomy of the brain that is concerned with the Parkinson's disease. So first let us draw the central nervous system. Right. Imagine this to be your central nervous system. This is your brain, the cross section of your brain, right? And now I'm going to introduce you to the basic players that are going to be involved in this Parkinson's disease. Okay. Now, this is your brain, the cerebral cortex, and what I'm drawing right now is your midbrain. All right. This particular area is your midbrain. Now, in the area of your midbrain, there is there is something what we call as, and you are very familiar with it, and that is called as your substantia nigra. So this is the first player of your brain that is involved in the disease Parkinson's. Now, basically, the substantia nigra and the other other places or other players that I'm going to introduce to you are nothing but masses of gray matter. Right. So this is the first thing that you have to take into consideration, the substantia nigra, which is located in your midbrain. Right. Now, after that, I'm going to draw the second structure, and that is referred to as your putamen. Right. This is your putamen, and directly above your putamen, you'll have a nucleus which is called as caudate nucleus. Right. Now, the speciality of caudate nucleus and putamen is that they are familiar in their histology. That means they will have striations on them, right? And that is the reason why caudate nucleus and putamen together, they are called as corpus striatum or striata to be to make it quite simple. So from now onwards, we are going to refer the caudate nucleus and putamen as corpus striatum. Right. Now, towards the medial side, that is towards the interior of the brain and attached to the putamen is another area which is important, and that is referred to as globus pallidus. All right, pallidus upwards is called as globus pallidus. Now, this globus pallidus is divided into two types, is divided into two parts. One is globus pallidus externa, and the other is globus pallidus interna. Right. Now, much interior to the globus pallidus, we have got the major or the prominent player of the basal ganglia, which is referred to as your thalamus. So this is your thalamus, right? And beneath your thalamus is a rectangular box-like structure, and that we call it as subthalamus because it is directly beneath the thalamus, and hence it is called as subthalamus. Now, the corpus striatum, the substantia nigra, the subthalamus, thalamus, and the globus pallidus, they are a single entity, and therefore they are referred to as your basal ganglion. Now, any pathology occurring in the basal ganglion will cause this neurodegenerative disorder, which we refer to as Parkinson's disease. Right. So let me write it down over here. First is your substantia nigra. Second is your corpus striatum. Corpus striatum is divided into putamen and caudate nucleus. Third is your globus pallidus. Globus pallidus is divided into globus pallidus externa and globus pallidus interna. Fourth is your thalamus, and fifth is your subthalamus. Now all these parts constitute your basal ganglia. And the circuits that are involved with these five parts, and if there is any pathology in the circuits of these five parts, it results in a neurodegenerative disorder which we refer to as Parkinson's disease. Okay, so let's continue. Now what I'm going to do is I'm going to draw a coronal section of the brain, all right, and I'm going to put these structures directly in the coronal section and explain it to you how they look in the coronal section of the brain. So for that, let us again draw the coronal section. Now, since I've drawn this, this will be your cerebral cortex. This will be your midbrain. This will be your pons, medulla, and the continuation will be your spinal cord. Now, apart from showing you all these structures over here, I am going to also show you some of the basic motor areas that will be associated with the disease Parkinson's. Right. Now, Parkinson's disease is basically a neurodegenerative disorder in which one of the clinical features is that the patient is not able to initiate movements. All right. That means the clinical features which the patient presents will be that of rigidity and immobility or dyskinesia. So to understand those clinical symptoms, we need to first understand the motor areas that are involved with those. So after drawing the basal ganglion in this particular figure, I am going to show you what are the motor areas involved with the disease of Parkinson's. Right. So first let us deal with the anatomy and then we'll go into the physiology of it. So since we are in the midbrain, let me first draw the substantia nigra. Right, here is your substantia nigra. Again, here is your substantia nigra. After that, let me draw the globus pallidus and the corpus striatum. This is the globus pallidus and corpus striatum, right? And I don't have space, so I'm just going to write here T, and beneath that will be ST, which is your subthalamus. Now, if you want to demarcate, above this will be your caudate nucleus, C, this will be P, this will be a caudate nucleus, putamen, and then we'll have to draw globus pallidus. Globus pallidus interna, globus pallidus externa. So all of these figures, they constitute your basal ganglion and they are involved in the Parkinson's disease. Now let me draw over here in the cerebral cortex the four most important areas which are involved in motor coordination. So what I'm going to draw is over here, I'm going to write this as PFA. Now PFA is your prefrontal area or your prefrontal cortex. Now the area above this, I'll write it as second, that will be your prefrontal motor area, right? Then third, this is your third. This will be your supplementary motor area. And lastly, fourth, this will be your primary motor area. Now, the reason why I'm telling you this is because any movements that you want to do, like it could be lifting up your pen, waving hi to your friend, or kicking a football, or batting, or writing an exam, or making chits and throwing at your friends, or clapping. Any motor coordination, any motor activity that requires coordination will be under the guidance of these primary areas in your brain, right? That means the prefrontal area and the premotor area, they will generate circuits that will be linked to your caudate and your putamen. And from here, the circuits will be given to your globus pallidus. They will be refined in your thalamus, and thalamus will send them back to your supplementary motor area and the premotor area. Now, after getting back the impulses, the second and the third, they are going to fine tune the impulses and give them back to the primary motor area. Now, this primary motor area, as you have already studied in your physiology, will give out corticospinal tracts. Right. Now, these corticospinal tracts, what they do is they give out certain neurotransmitters, and these neurotransmitters will fall on the lower motor neurons, and these lower motor neurons will ultimately release acetylcholine, and if suppose this is your muscle, they will cause the muscle contraction. This is a skeletal muscle. So basically your prefrontal area, your premotor area, they will give impulses or they'll give circuits to the basal ganglion, and the basal ganglion will fine tune it and give it to the thalamus, and the thalamus will again relay it back to the second and third, which are your premotor area and your supplementary motor area. Now these supplementary motor area, after giving the green signal, they will put it to your primary motor area. And from the primary motor area, as you know from your physiology, that this is the place where your corticospinal tracts arise. And the corticospinal tracts end in your lower motor neurons, which release acetylcholine that acts on the skeletal muscle and causes muscle contraction. So kicking a football, waving hi to your friends, or doing any activity will require this step. Now, this particular concept of physiology that I have just spoken about, this is referred to you as pyramidal system, right? Now, what is pyramidal system required to do? Pyramidal system is required for the fine voluntary movements of your body. Now, if you refresh your memory, you might also remember that apart from the pyramidal system, we also have got extrapyramidal system, right? So let me name a few of the extrapyramidal tracts that you have, right? You have got your oligospinal pathway, right? Just take this as your oligospinal pathway. And then let us draw your rubrospinal pathway. Right? Then you also have got your reticulospinal pathway. Let me write this also. This is called your corticospinal pathway. Now the ones in blues, they are referred to you as extrapyramidal pathway. Now, what is the physiology or what is the work of this extrapyramidal pathway? What do they do? As you already know, pyramidal pathway, they are involved in and they are utilized for the fine voluntary movements. Now, what are the extrapyramidal pathway required for? Now, before we go into the functions of these, let me first point out to you that the thalamus, since it gives out impulses back to the prefrontal area and the premotor area, the thalamus also controls these extrapyramidal tracts. They are under the control of thalamus, right? So that is one point that you need to remember. Now, the other point that you have to remember is that extrapyramidal system is involved or required for maintaining the tone of your muscles, right? Now, imagine you are going to kick a football, right? And you are going to kick a football with your right leg, right? You don't want your left leg to be contracting also in the same state. You want the tone of your left leg to be reduced so that the tone is increased in your right leg and you are able to kick the football properly, right? So those adjustments behind the curtains are done by your extrapyramidal systems, right? So it basically maintains the tone of your muscle. Second, it maintains the posture of your muscle. Imagine, you are waving to your friend. So what do you want to do? You want to lift up your hand and then wave. You just can't just maintain your hand at your abdominal level and wave. That is not the correct thing to do. So when you're trying to wave to a person, the fine voluntary movements, they are monitored by your pyramidal system. Now the posture, that means the level of your shoulder, the level of your arm, the level of your forearm, the way you are moving your fingers, right? That is maintained indirectly behind the curtains by your extrapyramidal system that are under the influence of your thalamus. Now, apart from that, the third and the most important thing or function that extrapyramidal system does is, and I'm going to write this in red, that is initiation of purposeful voluntary movements. Now imagine that you want to wave hi to your friend. All right. The thought that occurs first, that you need to wave hi to your friend because you have just looked at him. The thought that occurs, that is initiated by the extrapyramidal system. And then when that thought has been initiated, then the corticospinal pathway or the pyramidal system will come into effect, and then it will execute what you initially thought. So you require extrapyramidal system and also your pyramidal system for the maintenance or for the execution of any motor area, right? Now this is the reason why when babies are born, or let's say toddlers for example, do you think they can write? Do you think they can type? Do you think they can draw? They don't. Why? Because the motor programs, they are not basically executed or programmed in your brain. Now the programs or the storage of these motor programs are basically done by your basal ganglia. Now as you begin to grow older and as you begin to rightfully execute these motor programs by repeatedly practicing them, by repeatedly writing, by repeatedly moving your fingers, those motor programs gets embedded in your basal ganglia. And the basal ganglion then, depending upon what you want to initiate, will send impulses to your thalamus. Thalamus will fine tune those impulses and will give it to your premotor area and supplementary motor area. And these two will then forward it to your primary motor area. So that is how the initiation occurs, and then the voluntary movement of muscles begin. Now let us talk about the basic pathophysiology involved in Parkinson's disease. Now, Parkinson's disease, as I've already told you, it consists of circuits, neuronal circuits that help in the initiation and execution of motor programs. So what I'm going to do is, I'm going to take yet again draw a coronal section of your brain and explain it to you. right? Now, first, you have to understand two pathways which are related with your basal ganglia, right? First is called your direct pathway, and the second one is called your indirect pathway. Now, both these pathways are involved in the movement of your body, right? So you need to understand in detail what is the direct pathway and what is the indirect pathway, and how is it going to cause Parkinson's disease when pathology strikes, right? So let us understand first what happens. So let me first draw the basal ganglion, right? And this is, I'm going to just draw one side so that you remember it well, right? And here is your substantia nigra in the midbrain, right? And then here is your thalamus. Thalamus has got three nuclei: ventro-anterior, ventrolateral, and ventro-posterior. Hence the three divisions. And just beneath this, we have got your subthalamus. Now, let me draw the divisions over here. This is your striata, corpus striatum, and here we have got your globus pallidus externa and globus pallidus interna. Now, when you want to initiate a movement, right? Imagine that you want to pick a pen, right? So the initiation of thought that you want to pick a pen, it starts in the premotor area and your prefrontal area, right? So how does that initiation begin? How does that the initiation of thought begin? That begins with two neurons coming from the premotor area and prefrontal area. All right. So for the explanation's sake, I'm going to draw just two neurons coming from these areas. All right. So let me draw one neuron that is coming over here, right? It is releasing its neurotransmitter, and then we have got another neuron that is coming, and this is also your neuron that is releasing another neurotransmitter. Now, these two neurons, they are coming from the premotor area and the prefrontal area. Now, these two neurons are excitatory neurons. That means they are going to release excitatory neurotransmitters. And the excitatory neurotransmitters here are your glutamate, as we have discussed in our previous classes, that glutamate is an excitatory neurotransmitter. And the other neurotransmitter that is going to be released will be your acetylcholine. Right. So where are these glutamate and acetylcholine being released? They are being released in the striatum. Right. Now what happens? The striata, they have got their own supply of neurons. And the neurons that are basically what the basal ganglia is rich in is your GABAergic neurons. That means the neurons that are going to release GABA, right? Which is your GABA aminobutyric acid, which is an inhibitory neurotransmitter. So basically what happens is when the neurons, they release their own neurotransmitters, they will excite the neurons that are present in the striatum, and those are your GABAergic neurons. So let me draw over here the GABAergic neurons. And just look where this neuron is ending. It has crossed the globus pallidus externa and it has invaded in itself into the globus pallidus interna. Now this is the place where, if stimulated, it is going to release GABA, right? Now, the moment acetylcholine or glutamate comes and binds the receptors that are present on this GABAergic neuron, this particular uh, GABAergic neuron will get stimulated. action potential initiates. And when action potential initiates, GABA is released. Right. So if acetylcholine uh, stimulates this GABA, that means it will open up sodium ion channels, right? And if glutamate stimulates this GABA, that means it will open up calcium ion channels. You basically know the pharmacology that we have dealt in our previous classes on central nervous system. Now, when this GABA is stimulated, that means it is going to release an inhibitory neurotransmitter, right? Now, this inhibitory neurotransmitter will now act on another neuron that is now going towards the thalamus. So let me draw another neuron. Right. Now this neuron is also a GABAergic neuron. Right. Now we have heard the concept of paradoxical disinhibition in our previous classes. Right. Now what happens is that concept will be applying over here. Now from here, the GABA goes and binds to this GABAergic neuron. And when you inhibit an inhibitory neurotransmitter, what happens to the central nervous system? It gets activated. So basically what we are doing is we are going to give another neuron that goes from the thalamus, and this goes basically to your premotor area and your supplementary motor area. And it releases an excitatory neurotransmitter over here. All right. So this is referred to as direct pathway. That means the excitatory neurotransmitters or excitatory neurons that are coming from the premotor area and prefrontal area, they release the neurotransmitters in the striatum. This striatum will cause the activation of a GABAergic neuron that goes from the striatum into the globus pallidus internus. Now this globus pallidus internus, from the globus pallidus internus, another neuron arises that has got a link with the thalamus, right? And it is a GABAergic neuron. And from the thalamus, there is one more neuron that goes to the premotor and the supplementary motor area. Now, before I mention to you what happens exactly in the thalamus, let me remind you that thalamus is a place where the voluntary movements or the motor programs are fine-tuned. Right? That means if you want to wave to a friend who is exactly standing right in front of you, you don't wave to him in the east direction or the west direction when he's standing north to you. So what do? You take up your hand and you wave it to him in front of your face. That is your north. You don't wave it to him starting from the east, go to the north, and then you don't make a full semicircle, right? So what do? You just wave up your hand and you wave it right in front of him. How does that happen? That happens by the thalamus, because thalamus is the place where your motor programs are fine-tuned, right? Now the impulses that are coming from, or the circuits that are coming from the striatum through the globus pallidus external and the internals, they are very raw, and by the time they come to the thalamus, they get fine-tuned, right? And that is the reason why when you want to shoot a person in a competition, not in real life, when you want to shoot a person in competition, or you want to use an arrow and hit the bullseye, what you do, you make a point and you hit it. You don't go you don't go into the east or west direction, you directly hit your bullseye. How does that happen? Because of this thalamus, because thalamus is the area where your motor programs gets fine-tuned, right? So this is referred to as the direct pathway. And then impulses from the premotor area and the supplementary motor area are now given to the primary motor area. And from the primary motor area, as I've explained to you in the previous slide, the corticospinal tracts arise, which end up at the lower motor neurons and cause muscular contraction. Now, after having read about the direct pathway, let us now talk about the indirect pathway. So what happens in the indirect pathway is that The glutamate neurons and the acetylcholine neurons, they come into the striatum, they release their neurotransmitters. The only thing that is different over here is that we have got the GABAergic neurons, right? Now, in the direct pathway, they were going right into the globus pallidus internus. Now, what happens is we have got a GABAergic neuron. We have got a GABAergic neuron, and that GABAergic neuron will end up in the globus pallidus externus. It was going, the direct pathway neuron was going into the internus. Now, this will end up in the externus itself. Now, what happens over here is that this GABAergic neuron that is from the present in the globus pallidus externus now will send up another GABAergic neuron into the subthalamus. So let me draw subthalamus again for you. Just don't mind the substantia nigra, which is too close. It's not actually the anatomy of it, but for understanding sake. Now, since you have drawn the subthalamus, let us draw a neuron that is coming from the globus pallidus externus and ends up in your subthalamus. So this is the thing that happens. This is the first step in the indirect pathway. The acetylcholine and the glutamate, they have now excited this particular GABAergic neuron, right? And now this GABAergic neuron will release GABA and onto the next GABAergic neuron. Now what happens is there is another neuron that arises from the subthalamus and goes into the globus pallidus internus. Right. So this is what is happening in the indirect pathway. You have got a neuron that arises from the striatum, ends up into the externus, globus pallidus externus, and from the globus pallidus externus, a neuron enters the subthalamus, right? And a neuron from here will go into the internus, and from the internus, the same story begins. Right? So this is referred to as indirect pathway. Now, to understand that, I have to draw first your substantia nigra. So let me draw over here your substantia nigra. Right. Now, this is the place where the initiation of movements begin. All right. Now, from here, you might have heard we have got your nigrostriatal pathway. You might have heard this in your physiology of a pathway which is called as nigrostriatal pathway. Now I'm going to explain it to you how the nigrostriatal pathway is involved in the motor programs of our body. So first let me again draw the basal ganglion. Right. So now what happens is from the substantia nigra there arises two neurons. Right. So let me draw neuron number 1. All right. This is neuron number 1 and this is neuron number 2. Let us name this as neuron number 1 and neuron number 2. Now, the point of importance of these neurons is that these both are dopaminergic neurons. That means they will release dopamine. Right. Now, this dopaminergic neurons, this particular neuron number 1 has got D1 receptor, and this neuron has got D2 receptors. And you know from your pharmacology that D1 receptors are GS coupled and D2 receptors are GI coupled, right? Now, let us take the neuron number 1. When dopamine is released, right, through the neuron number 1, the dopamine 1 receptors which are present on the GABAergic neuron, right, that ends up in the Globus Pallidus externa, right? This is your dopamine receptor 1 present on the GABAergic neuron. Now, before that, we have got acetylcholine coming from the premotor area and your primary premotor area, and also your prefrontal cortex. And we have got glutamate also, that is coming from your premotor area and prefrontal cortex. Now, these have also got receptors on these GABAergic neurons, right? Now, dopamine will go and bind to this particular D1 receptors. Now, D1 receptors, as you already know, they are GS coupled. That means they are G stimulatory. That means they will excite this GABAergic neuron, right? When the GABA neurons is excited, what happens? GABA is released, right? Now, GABA is an inhibitory neurotransmitter. Now, if you remember the direct pathway, that means from the globus pallidus internus, there is another neuron, GABAergic neuron arising, right? So let us first draw that, and then we'll go. Now, this is the another GABAergic neuron that you are drawing, right? Now, you know from your previous CNS chapters that when GABA acts on a GABAergic neuron, it will actually inhibit it, right? That means a GABAergic neuron or a negative neurotransmitter or a de-excitatory neurotransmitter, when it inhibits an inhibitory neurotransmitter, that means the resultant will be whatever is happening down the stream after this will get positive, right? So now, since this has got disinhibited, what happens is the glutamate receptors or the glutamate neurons that were arising from the thalamus, they will get excited. And when they get excited, they will carry on the impulses towards the primary motor area from the supplementary area. Right. So this is about the dopaminergic neuron number 1. Now, what happens to the dopaminergic neuron number 2? Now, this dopaminergic neuron number 2, it has got receptors on which it acts, and those receptors are D2 receptors, which are GI coupled. Right. So let us look at what happens when we draw a GABAergic neuron. Now, this is the GABAergic neuron that we are drawing, and it ends in the globus pallidus externa. Right. Now, this is the second dopaminergic neuron, and it acts on the D2 receptors. D2 receptors are present over here, right? Now, D2 receptors are GI coupled. That means they will decrease the cyclic AMP. And when they decrease the cyclic AMP, that means what are they doing? They are inhibiting this neurotransmitter, right? So what happens? Nothing happens. GABA is not released from here, because the D2 receptors, when they are activated, they are GI coupled and they will inhibit this neurotransmitter. So nothing is going on over here. No neurotransmitter is being released. So what happens to the next neuron in the indirect pathway? It gets excited. So let us draw that neuron first. Now this neuron is going where? It is going to the subthalamus. Right. Now from the subthalamus, it is releasing GABA, right? And this GABA is acted on the next neuron that is now going to the, where is it going? It is going to the globus pallidus internus. Right. Now this is a glutamate neuron. Now ultimately what happens is, the again we are going back to the globus pallidus internus, where this particular neuron gets inhibited, and when it gets inhibited, the glutamate neuron that we have over here, it gets stimulated, and then it goes and does the excitation of the primary motor area. And from the primary motor area, the corticospinal tracts arise and they cause the motor programs to initiate. Now, what happens in Parkinson's disease is that these dopaminergic neurons that we have in the substantia nigra, that are arising from the substantia nigra and that we have referred to as nigrostriatal pathway, they get degenerated. That means it's not that we just have one neuron coming, one neuron acting on the D1 receptor and one neuron acting on the D2 receptors. We have got thousands of neurons, lakhs of neurons that are in this particular pathway, the nigrostriatal pathway. And what happens with age or with certain toxicities in a body, or through radical influences or some toxins, there will be neurodegeneration of this particular pathway. And if you go into the pathology, you will find that there will be accumulation of Lewy bodies. So when that happens, these neurons get destroyed or degenerated. And when that happens, the complete opposite effects of the direct pathway and the indirect pathway occurs, in which what happens is, instead of this particular neuron getting inhibited, it gets activated. And when it gets activated, it will release GABA over here and inhibit the glutamate neuron over here. And when this excitatory neuron is getting inhibited, that means it won't be able to send impulses to the premotor area and the supplementary motor area. And when they get inhibited, they won't be able to send impulses to the primary motor area. And as you all know, that from the primary motor area arises the corticospinal tract, and that ends in your lower motor neuron coming out and directly causing contraction of the skeletal muscle. So that is what happens in your Parkinson's disease. So you need to understand the direct pathway, which involves GABAergic neurons arising from the striatum and going directly into the globus pallidus internus. And from the globus pallidus internus, it goes into the thalamus. And from here, another excitatory neuron arises that goes into the primary motor area. In the indirect pathway, uh, the GABAergic neurons travels to the globus pallidus externus, and from there it goes to the subthalamus, and from the subthalamus another neuron goes to the globus pallidus internus, and then from here it goes to the thalamus, wherein an excitatory neuron arises and goes to the primary motor area. Now in Parkinsonism, the dopaminergic neurons of the nigrostriatal pathway, they get degenerated, and when they get degenerated, for example, if the GABAergic neurons are not stimulated, that means they will not be releasing GABA over here. And when they are not releasing GABA over here, what happens? This particular neuron will not get inhibited. And when it doesn't get inhibited, that means it will release GABA over here. And when it releases GABA, the next neuron, which is your glutamate neuron, will not get excited. And when it doesn't get excited, what happens? The resulting result is that the primary motor area will not get excited, and the contraction of muscles cannot happen. Right. So this is what happens in the disease of Parkinson's. Now, if you look at the pharmacological or the biochemical aspect of it, what happens is, in normal physiology, there is a balance between dopamine and acetylcholine. Now, since I have mentioned that the nigrostriatal pathway gets degenerated, the levels of acetylcholine will go up and the levels of dopamine will go down. It's not that the levels of acetylcholine are going up, it's just that the levels of dopamine are going down. So from here, we get the pharmacology over here is that we need to give drugs that are dopamine rich, or we have to replace the dopamine which has been lost, or you can either give anticholinergics. So this is one of the simplest pharmacotherapies that we have for the management of Parkinson's disease. Now there are multitude of drugs that are involved for dopaminergic drugs, and there are multitude of drugs that are involved with this therapy also. So we'll leave this particular section for the next class, and we'll focus more on the clinical features of Parkinsonism here. Now the clinical features, the first clinical feature is that there will be difficulty in initiation of movements. Right. Now this is because of less dopamine, because the initiation was done when dopamine was being released into the basal ganglia. Now this is referred to as hypokinesia. Now the second thing is the patient presents with rigidity. This is why, because the tone of the muscles are increased. This is because of increased acetylcholine. Third, there will be loss of balance. There will be tremors. This is also because of acetylcholine. Then there will be postural abnormalities. Fifth, there will be mask-like face, also called as serpentine look. You know, the patient, they look at you without blinking, and you already know that snakes, they don't have eyelids, they just look at you. That is referred to as serpentine look. And the characteristic fascinating gait. The patient takes small steps because they have difficulty in initiation, and when they have initiated movement, they have difficulty in stopping. That is called as fascinating gait. And then the characteristic, this is important for your medicine final year, flagpole sign. That means if a Parkinson patient is walking and you just give him a small nudge, he falls down like a pole, because his reflexes are not that good and he won't be able to stop himself. So he falls down like a pole, flagpole sign. And the characteristic feature of this particular patient will be that if you ask him to write his name, he starts with capital letters, he starts with a big strokes, and ultimately this is what happens, right? So this is one of the most important clinical features. And there is something that you have to remember, that if you give patients or if you give patients or keep patients on dopamine antagonists, they will come up with drug-induced Parkinsonism or extrapyramidal effects of those drugs. This is referred to as pseudo-Parkinsonism because this will go when you remove the drugs. Now, this is about the clinical features. Now, the Parkinsonism that we have studied, it is one of the uh, motor programs that is hampered because of degeneration of the nigrostriatal pathway. Now, there are other motor programs also that are hampered because of different pathologies in different areas of the basal ganglia. Let us take a look at that. First is, you might have heard it in your medicine postings, that is referred to as chorea. Now, this chorea is actually the coriform movements exhibited by the patients. Now, what happens over here is that there will be purposeless jerky movements occurring. Right. Now, the pathology will be actually in your caudate and putamen, or you can simply put it as corpus striatum. The second abdominal movements that you have to remember is called your athetosis. Now, these athetosis, they happen when there is pathology in your globus pallidus. These are slow, spontaneous, rhythmical movements. It is as if the patient is dancing in a slow way. Then third, you have got hemiballismus. Now, hemiballismus is actually uncontrolled girdle movements. And this is the pathology occurs in the subthalamus. And lastly, that we have studied Parkinson's disease. The pathology is in your substantia nigra. So apart from the abnormal movements that are seen in the Parkinson's disease, these are also the other things that you have to remember. Chorea, athetosis, and hemiballismus. Now, chorea, we have got actually two examples that are asked time and again. First is your Huntington's chorea, wherein what happens is we have studied about the GABA neurons. There will be degeneration of those GABA neurons. And then we have got Centvitis chorea. This basically occurs in patients having rheumatic fever. So your basal ganglion is involved in that. So this is about the anatomy and pathophysiology of Parkinson's disease.